This is pharmaphorum web editor Nicole Raleigh, and I am on site at ASCO 2025 in Chicago at McCormick Place. And with me today is Dr. Jason Williams, who is Director of Interventional Oncology and Immunotherapy at the Williams Cancer Institute. Pleasure to speak with you, Jason.
Pleasure to speak with you as well.
So the Williams Cancer Institute specialises in minimally invasive procedures aimed at improving outcomes for patients with various types of cancers. And Dr. Williams is pioneering the use of intra-tumoural immunotherapy and pulsed electric field, or PEF therapy, to reshape how tumours are treated, offering new hope to patients who may not respond to conventional approaches. Firstly then, Jason, can you tell us more about the Williams Cancer Institute?
Sure, yeah. So we're a practice. We have multiple locations, a few in the U.S. We also have a few outside the United States in Mexico, Mexico City, and Cabo San Lucas, Mexico. And we do pulse field ablation with intratumoral injection of immunotherapy. We do mostly all solid cancers. I mean, our big strength, pancreatic is one, prostate another. We do a fair amount of breast. We do a fair amount of all different solid cancer, sarcomas as well. The technique, for me, I've been in the ablation area for more than 20 years. And what I was seeing is that when we were destroying some of the tumors, that we were getting these immune responses, and that was improving the overall response for the patient. Then as the immunotherapy started coming along, we started injecting them into the tumor, and something that worked even better, because really the immune action you want to occur in the tumor site. It's like creating a vaccine there. And so it allows you to use more combinations of drugs, and so we see a better effect with less side effects. And so that's our main premise. We have lots of things. I wrote a book, have a second book coming out, where we talk a lot about the gut microbiome, obviously a huge area, using off-label drugs like medicines that were for other things and repurposing them for cancer treatments, using them to enhance cancer treatments, and also the things that like patients should avoid when they're on immunotherapy that may interfere. I mean, particularly we know acetaminophen or paracetamol being, one that interferes with immunotherapy, and a lot of people are not aware of that. And so we try to educate everybody on those things.
Yeah, absolutely. Did you want to share the title of the book at all?
My first book is The Immunotherapy Revolution. The second book, we have not made it, it's finished, but we haven't decided the title yet.
Okay.
So that one should be coming out maybe six to 9 months from now.
Okay.
But that one, the book unifies a little bit of how aging and cancer. So it talks a lot about, of course, the standard immunotherapy and gut microbiome, all of the same things, and repurposed drugs, but also how we figured out that cancer and aging are very similar diseases in the fact that cancer cells and old cells do the same type of thing to hide from the immune system. And what we were seeing with some of the immunotherapy drugs is it was making the tissues younger. Yeah. And so we were seeing this age reversal. So that's the book has a lot of discussion about that.
Okay, so more to be revealed very soon. Okay, so let's go back to intratumoral immunotherapy.
Yeah.
So can you share some more about the developments as well as PEF therapy?
Sure. Yeah. So one, intratumoral immunotherapy is just when we stick needles in tumors to biopsy them. So you have that opportunity to inject medication into the tumor. A lot of these immunotherapy drugs are monoclonal antibodies that bind to receptors and affect the immune cells. And so you want to really affect the immune cells where the tumor's at. And so putting them in the tumor site is more appropriate, and you get better delivery. And you don't have to have it everywhere, right? If you teach the immune system in one spot, then the immune system knows and may attack the other areas. So you may have some areas of resistance that you have to target directly. But we can hit most cancers with needles because we are biopsying them. Then when we have the pulse electrical field, that's a ablative technology. So where you're using a needle and using an energy technique to destroy cancer. People classically know radiofrequency ablation or microwave ablation or cryoablation. And some of those have some immune stimulating properties, but this pulse electrical field, which is like a very quick electrical discharge that pulses, has a much better immune stimulating properties than the company that developed that. They're called Galvanize. They've done lots of studies showing how they're boosting the immune response, and if you do that in conjunction with immunotherapies, it enhances it. So since we're in there with the needle and we can do it, we just do a small amount. You don't have to do the whole area. It's kind of the difference. People always before think that, well, you got to ablate the whole tumor. No, you actually just ablate a small piece. We found if you ablate the whole tumor, it's actually counterproductive. So doing a
right.
small area is better. So yeah, that's kind of the main thing of that. And of course, the big advantage of intratumoral immunotherapy is one, you can use broader combinations of drugs. I mean, so we're actually using 12 plus drugs, sometimes 16 drugs even. You could never do that systemically. That would create such huge problems. But these are like low doses in the tumor, and so you're hitting all these different receptors and affecting, generating that immune response. And yeah, and then the pulse field itself acts like another immunotherapy on top of that by killing some tumor, helping deliver the antigens. And then when you're delivering drugs that maybe help stimulate the dendritic cells and other cells to see those antigens at the same time, you're boosting that whole thing together.
It's fascinating science.
It's it makes a lot of sense. I don't know why people didn't really catch on to this sooner. It really surprises me because to you would really think you want to go to the tumor first. I mean, you can still use systemic drugs. I mean, the issue, people always say, well, cancer is, when it's spread, it's a systemic disease. It is, but still, that doesn't mean you don't want to do something in the tumor. You could do both, and that's the other thing, is that this therapy plays well with others. So, like for example, in pancreatic cancer, a lot of times we'll have patients and they're going to get standard of care like FOLFOX, FOLFIRI, and we'll do our treatment with it. So in their off weeks, they get with us, and we do both at the same time. They do way better. Um, hopefully in the future, we'd like to be able to eliminate the chemotherapies, and we can for some cases. But cases like that, you get a better, quicker response if you do them together. We can treat it without the chemo, but that's a longer process because we're having to really stimulate the immune response. And the chemo in that situation helps by shrinking the tumor some, for it makes it easier for the immune system. But you try not to give the patient so much chemo that they start getting immune suppressed, because ultimately you start converting the immune suppression, then you start inhibiting your immunotherapy.
Yeah, it's balance.
Yeah, it is. Yeah. It is. Yeah.
So let's come away slightly from the specifics of your area of expertise for a second. And a question that pharmaphorum's been asking, as viewers of this interview will realise, is what, in your opinion, is being somewhat overhyped, and what, conversely, is being underappreciated?
Well, yeah. So, I'll be honest, and I think people are not going to like this, but I think that a lot of the cell-based therapies and things like the TIL or even CAR T, particularly in solid cancers, are actually overhyped. I think they think that's going to be a bigger answer, but the problem with that is that that's still a one-dimensional approach, and so when you attack a solid cancer that way, it's going to get around it. And that's why I think the intratumoral approach, on the contrary, where you're hitting many receptors and you're affecting many parts, that's why I think it's better. And I think that these other cell therapies, obviously they're difficult to do. They're very expensive. So I know that they see results, and I know that they're seeing a positive, but I don't see that being the ultimate cure in a lot of cases. Now, there's some exceptions. I think some of the hematologic or bloodborne cancers, are doing quite well with CAR T, but I think the solid ones are still very questionable, and so I think that's an area that's probably overhyped, in my opinion. So, and I think maybe underappreciated. Well, I mean, it's hard to say. I think the pulse field, obviously is an area that maybe the medical oncologist not recognizing that could be an adjunct to patients getting immunotherapy, and so that's one. I would say maybe gut microbiome, but I think they're starting to recognize that now. I mean, I think the only thing is that they're recognizing it, but maybe they're not doing enough to treat it, because there are options. I mean, you do have like fecal transplants like Rebiota, but the problem is that insurance doesn't pay for those for this situation. We're actually doing some studies with Ferring Pharmaceuticals that has that to try to change that to where this could be used as a cancer treatment, because we actually saw patients where we knew their gut microbiomes were bad. We gave them Rebiota, and their cancers actually shrunk before we started treatment, before they had anything, with fecal transplant. And so we know that it does something. Obviously it's not I'm not saying it's curative or anything, but it improves that immune response naturally. And then for cancer patients, immunotherapy, having a good gut microbiome is very important for the therapy to be successful.
No, absolutely. That's fascinating also.
It is, yeah.
So, if you could solve one major problem in oncology over the next decade, what would it be? Huge question, but go for it.
Oh, and I have an area, and it's my favorite area, that the treatment should start at the time of biopsy.
Hmm.
That you should not stick a needle in a tumor and not at least put something in it, do something to it. You could pulse field ablate it. You could inject even non-steroidal anti-inflammatory drugs like ketorolac, stuff that's simple. You can inject the flu vaccine, various things that would be easy and inexpensive. I'm sure we can come up with a regimen that would not be harmful to any of the patients, but you don't want to stick a needle in the tumor and then leave it alone. There was a study last year showing that inflammatory response of the biopsy converts it into being a more aggressive tumor and suppressing the immune response. And so we're going and biopsying these, and then we're waiting weeks or months before we even start treatment.
Yeah.
And we should start the treatment at the time of biopsy. And I think if we do that, that we'll see a significant improvement in the patients, and they'll see a lot less metastasis, and the patients will do much better. So that's what I'd like to see. The challenge with it is obviously still payers, insurance covering that, particularly in the U.S. We're working with a few other countries that where they're more government supported, so they may be more open to this type of thing because it's a cost savings. I think unfortunately in the U.S. they just look for new therapies that are more expensive and try to do more and more expensive things. And when you come to them with something that actually is going to save a lot of money, they're hesitant, right? They don't want to put money into that. So that's been the challenge.
That's true. Okay, so my final question,
Yeah.
and it might not be an easy question, but what has been the sort of key takeaway for you from ASCO 2025, Jason?
Yeah. Well, so I mean, a few things. I mean, one, our company Synchromune presented our SYNC-T data in prostate, and obviously that's impressive. And I think people were really surprised and saw that. I mean, because we showed scientifically that going into the tumor that we're generating, all these like T cell receptors like attacking the cancer. So it's like this epitope spreading, and that's something that well, to be able to show all that is in human patients is very, very important and way better than you see with other therapies. I mean, the amount of epitope spreading that was incredible. So, I think people are starting hopefully to catch on the idea that intratumoral immunotherapy is really a great option.